chairpersons, distinguished faculty. At the outset, I'd like to thank Dr. Vijayakumar and his organizing team for inviting me here. So first few slides I'll talk on little bit on the screening and then go on for the guidelines. And I think most of the people know about these slides. The ethnicity, we know Indian women have increased risk of developing glucose tolerance during pregnancy compared to Caucasian women. Among ethnic, again you talk about Indian women, South Asians and Indian women have the highest frequency of gestational diabetes. So diagnosis is essential in non-pregnant women. So in terms of screening, universal screening is warranted, especially in the Indian context. Then the second part, we'll go on to early screening. Do we need early screening? So this is a study from Japan, if you can see. Almost they diagnose the entire 100% before the recommended weeks of screening. This tells us the importance of early screening. What are the implications of early screening? Why do you want to screen them early? What happens? Does severe macrosomia we talked about manifest early than the recommended 20-24 weeks of screening? Yes, it does. How? Severe macrosomia manifests as early as 11th to 14th week of gestation. You can see the pathophysiology here. Each islet cell functions as an endocrine organ and is able to differentiate at 10th to 11th week of gestation and recognize and response to maternal glycemia by about 11 to 15 weeks of gestation. So screening around the 16th week itself you can pick up. So this is what happens. The fetus are exposed to increased amniotic fluid glucose before 15th week, suggesting that metabolic alterations are underway before diagnosis. An earlier screening and intervention may be warranted, and this is one of the causes where we see macrosomia in spite of normoglycemia, we call it, because we don't pick them up early. So let's see whether in our study the GDM manifests in all trimesters or not. So the prevalence we see whether for 4,151 women screened, about 17.9% are gestational diabetes. And when you look at them in terms of the 16th week of gestation, you can see about 16%, 17 to 23, you have about 22%, and the green more than 24, 61%. So GDM manifests at all trimesters of pregnancy. The most important what you should know from this slide you see here, 38% of women were diagnosed even before the recommended weeks of screening. And also the WHO now endorses that testing in early trimester is recommended. Also, one of our study we published 2 years before, need for testing glucose tolerance in early weeks of pregnancy. Again, if you take the cartoon here, you can see the GDM, the trimesters. 1/3 of all GDM cases were diagnosed before the recommended weeks of pregnancy itself. There is another study by Bata and group. They found that people who have been picked up late had features of hydramnios. You can see the percentage difference. Then preterm deliveries, premature rupture of membranes and fetal anomalies. So early glucose tolerance should definitely be beneficial in these patients, especially in an Indian scenario. The implication for all this is early maternal metabolic imprinting may affect fetal growth. In other words, it is the fetal programming of the adult pancreas which we are bothered about. That's where you take pregnancies a very short time where we can manipulate so that we prevent intergeneration transmission of diabetes and also primordial prevention of diabetes. So let's see now, you do early screening, but what is the benefit? We pick them early, we get a better outcome. This is our study which you can see here. 207 pregnant women at a center we are given, and we had a very high percentage of 42 because ours is a tertiary clinic. So when they were divided into two groups, the group 1 detected between 0 to 23 weeks and group 2 detected beyond 24 weeks of gestation. And they were all treated to the same outcome with the same HbA1c, and when you found the outcome who were picked up earlier had the birth weight as similar to a normal gestational women, normal glucose tolerant women, whereas you see people who are picked up later in spite of the good control, they had much much higher birth weights. So this shows that we can pick them early, screen them early, pick them early, treat them early, you definitely get beneficial effect. Now when we go on to early screening, what about repeat screening? So you see them once, you say they are negative, we're going to leave them alone? No. So you have to have repeat screening. Our study here shows that women with normal glucose tolerance in the first visit were screened with subsequent visits, and you found 28% of women were detected to have GDM in repeat screening. So ladies and gentlemen, you have to screen them subsequently, not leave them once they're found to be negative. Now we go on to the DIPSI criteria for diagnosis and guidelines. The paper is mainly from Professor Anjalachi and us who are sitting there with us. This has given us a lot of insight. So this is exactly what the paper says: 2-hour post-glucose greater than 140 with 75 gram oral glucose administration, pregnancy women in the fasting or non-fasting. Don't think it's only non-fasting. No, it can be fasting or non-fasting. Without regard to the timing of the last meal, is able to identify women with gestational diabetes. So this is exactly what the DIPSI guidelines now been approved by a lot of organizations. I'll come to it next in the subsequent slides. The State Health Society operational guidelines for screening and diagnosis of GDM in the community. The screening process: first screening ideally 12 to 16 weeks or at the time of the first visit. Second screening 24 to 28, and third screening 32 to 34 weeks. And this is the Ministry of Health Family Welfare, where they are given approved for the one-step test for universal screening during pregnancy, and supply of glucometers to all SEP centers, and one-step test is taken into the National Program for Prevention and Control of Non-Communicable Diseases, where this is also as an add-on. And glucometer study, we already studied and published this paper, which says the CBG value 2 hours even done by glucometer is also applicable, and use glucometer standardization for measuring plasma glucose. And the WHO also endorses, saying that laboratory glucose measurements not available, we can use the glucometer as an option. So the WHO observation recommendation 2013, we were part of it. This is what it says: for a pregnant woman, request to attend fasting may not be feasible. Consequently, a non-fasting testing may be the only practical solution. And you can see here WHO recommends a single-step procedure to diagnose gestational diabetes. And the strategies to describe under the WHO, the second part you can see again, it says measuring non-fasting values as one of the strategies, and where feasibility of doing everything may not exist. And this is the FIGO guidelines, which was published in International Journal of Gynecology and Obstetrics, which again says Indian subcontinent plus medium to low resource setting, serving ethnic population at high risk, 2-hour value of 70 gram OGDT, fasting or non-fasting value greater than 140 is gestational diabetes. So all women need at booking. This is the 6th December 2017, a FIGO IDF joint statement and declaration on hyperglycemia and pregnancy. Done recently, it says all pregnant women attending health facility tested for hyperglycemia, occurs advocated by FIGO, IDF and WHO, and also to promote and celebrate GDM awareness. And this is now February 2018, about 3 months ago, where the Maternal and Division Ministry of Health and Family Welfare has said approved the single-step procedure. This is exactly they want to do: universal testing for gestational diabetes, where testing for GDM at first antenatal visit, and then positive 2 hours greater than 140 managed as GDM, and subsequently rescreen them and then treat accordingly. This is just 3 months ago. The guidelines by DIPSI has been followed by the national policy. So India's contribution under Professor Dr. Seshaya made an impact on GDM diagnosis and management, accepted by FIGO, accepted by World Health Organization, accepted by the IDFO, and also as an Indian national guidelines. So summarizing, ladies and gentlemen, ethnically Indian women are more prone to develop gestational diabetes. Universal screening is necessary in the Indian setup. Customized screening facilities don't exist. You can do the DIPSI guidelines where we do not want any pregnant women devoid of testing. And if you have, and the GDM is diagnosed if the 2 hour is more than 140, a single test that is cost effective and reliable, especially in clinics, if you have all the facilities, you can go with the routine conventional method, and then screening for glucose intolerance, earliest opportunity during pregnancy, and repeat screening when negative. Thank you.